Hello and welcome back to Pharmacomania. I'm Dr. Shanaz Malik with Skeletal Muscle Relaxant. So what is skeletal muscle relaxant? So it is the group of the drug that act peripherally at the neuromuscular junction or at the muscle fiber itself or centrally in the cerebrospinous axis to reduce the tone of the muscle or the paralysis of the muscle. So this is the physiology of skeletal muscle contraction. Motor, whenever now impulse generate release of acetylcholine and bind with the neuromuscular at the neuromuscular junction. Depolarization and development of the end plate potential occur at the motor end plate. And muscle action potential generate and contraction of the muscle occur. And now acetylcholine is rapidly inactivated by cholinesterase enzyme at the muscle end plate and leading to repolarization occur. And now muscle is ready for the fresh nerve impulse generation. Now classification of the skeletal muscle relaxant. There are two kind of the muscle relaxant, like centrally acting muscle relaxant and peripherally acting muscle relaxant. So centrally acting muscle relaxant are diazepam and other benzodiazepines, methacarbamol, chlorzoxazone, tizanidine, baclofen and thiocolchicoside. These are the centrally acting muscle relaxant. Now peripherally acting muscle relaxant are drugs acting on the neuromuscular junction, and other is the directly acting skeletal muscle relaxant. So drugs acting on the neuromuscular junctions are three types, like first is the depolarizing blocker, non-depolarizing blocker, and third is the other. So first one is the depolarizing blocker like succinylcholine. It is similar to acetylcholine and it depolarizes the muscle. Other is the non-depolarizing blocker, is a competitive kind of the blocker, and it compete with the acetylcholine and it block the receptor and inhibit the contraction. And third is the other like blood botulinum toxin. Now, centrally acting muscle relaxant are like mefenacin congener like chlorzoxazone and methacarbamol. Second group is benzodiazepine like benzodiazepam and other benzodiazepines drug. GABA mimetic drug like meclofen and thiocolchicoside, and centrally acting alpha 2 agonist is the tizanidine. Now, centrally acting muscle relaxant, most of the centrally acting muscle relaxant are available in combination with the NSAID. All of them causes certain degree of sedation, and they act by depressing polysynaptic pathway in the spinal cord and supraspinous state. They are used to reduce spasm associated with cerebral palsy, trauma, sprain, tetanus, multiple sclerosis. So these all condition are when centrally acting muscle relaxant can be used. Acting muscle relaxant like baclofen, it is GABA B agonist and it facilitates GABA, and it is orally active and uses for the spinal cord lesion, multiple sclerosis, amyotrophic lateral sclerosis, and adverse drug reaction of the baclofen are drowsiness, dryness of mouth, diarrhea, confusion, ataxia, and vomiting. So second drug is the diazepam and other benzodiazepines. It also facilitates GABA A and it is GABA A agonist. It is orally as well as parenterally active, and uses are tetanus and other conditions associated with muscle spasm, and adverse drug reaction are sedation and drowsiness. Third drug is tizanidine. It is centrally acting alpha 2 agonist. It is orally effective and uses for the multiple sclerosis, spinal cord injury, or spinal cord diseases, and adverse drug reaction like drowsiness, dizziness, disorientation, and ataxia. These are all side effects of the alpha 2 agonist. Chlorzoxazone and methacarbamol act on the spinal interneuron, and it is orally effective. It is used in the acute muscle spasm due to trauma, and adverse drug reaction is the drowsiness. Riluzole is it inhibit glutamate release and uses for amyotrophic lateral sclerosis, and adverse drug reaction is the diarrhea. Thiocolchicoside is the orally useful and used in the sprain and muscle spasm due to trauma, and adverse drug reaction is diarrhea, drowsiness, and rashes. Peripherally acting muscle relaxant are neuromuscular blocking agent and directly acting agents. So first is the neuromuscular blocking agents are non-depolarizing agent and depolarizing agent. Depolarizing agents are succinylcholine and decamethonium, and non-depolarizing blocking agents are longer acting, intermediate acting, and shorter acting. So longer acting are D-tubercularine or DTC, pancuronium, doxacuronium, and pipacuronium. Second group, intermediate group is vacuronium, etacuronium, rocuronium, and repacuronium. Shorter acting is the mevacuronium. Now, depolarizing neuromuscular blocker like the succinylcholine, it is the similar to acetylcholine, and it is quaternary ammonium compound, and structurally resemble to two molecules of acetylcholine and linked together. It acts as a partial agonist at the neuromuscular receptor. Initial fasciculation, it binds with the neuromuscular receptor and activate the neuromuscular receptor because it is partially agonistic activity. So it activates the neuromuscular receptor, and depolarization of the muscle can occur. Initially fasciculation and later flaccid paralysis due to prolonged depolarization occur. With continuous exposure to the drug, the membrane become desensitized, which lead to phase 2, which resemble to non-depolarizing block, and it is partially reversed by anticholinesterase enzyme. So, succinylcholine is rapidly hydrolyzed by pseudocholinesterase and has very short duration of action is 3 to 8 minutes. Transient apnea is usually seen at the peak of its action, and in the people with the liver diseases like atypical pseudocholinesterase due to genetic defect, the metabolism of the succinylcholine becomes slow, which result in severe neuromuscular blocking and prolonged apnea can occur. Apnea occur due to the succinylcholine is called succinylcholine apnea. There is no antidote of the succinylcholine apnea. But fresh frozen plasma should be infused to wash away the succinylcholine because fresh plasma contain pseudocholinesterase which hydrolyze the succinylcholine. Anesthesia should be continued until the recovery from the neuromuscular blockade. Patients should be ventilated artificially until fully recover. Now, adverse effect of the succinylcholine. Muscle pain is due to initial fasciculation of the muscle and soreness can occur. Increased intraocular pressure due to contraction of the extraocular muscle, and it lasts for the few minutes. And aspiration of the gastric content may occur due to increase the intragastric pressure, and hyperkalemia occur due to fasciculation and release the potassium into the blood. Due to vagal stimulation, sinus bradycardia can occur, and succinylcholine apnea can occur due to prolonged apnea. It is the succinylcholine apnea is the prolonged apnea due to genetic disorder. Now, malignant hyperthermia, especially when they used with the halothane in genetic susceptible patient. Malignant hyperthermia can occur, and it is treated by intravenous dantrolene and rapid cooling and inhalation of the 100% oxygen to control acidosis. Now, non-depolarizing neuromuscular blocker like D-tubercularine, it is used as a arrow poisoning for hunting. Claude Bernard showed the experimentally the site of action of the curare. Curare is the mixture of the alkaloid and used in the hunting. D-tubercularine or DTC is the most important alkaloid which has neuromuscular blocking activity and is prototype drug of the competitive, and D-tubercularine is the prototype drug of the competitive blocker. Now, mechanism of action of non-depolarizing neuromuscular blocker. So, acetylcholine is the agonist at the neuromuscular receptor, and DTC is the antagonist of the neuromuscular receptor. These both agent, acetylcholine as well as DTC, compete for that neuromuscular receptor, and whenever acetylcholine bind with neuromuscular receptor, then action will appear like the contraction of the muscle, and if DTC is bind to that NM receptor, then it DTC block the action of the acetylcholine and muscle paralysis or reduce the tone or atroponium is added Then it reverses the action of the D-tuberculin by increase the concentration of the acetylcholine at the neuromuscular receptor, and again contraction of the that particular muscle can occur. Now some non-depolarizing blocker are like it is post histamine release, ganglionic blocked, and has longer duration of action. When pancuronium is also non-depolarizing agent and it is synthetic agent, produce competitive blockade, has longer duration of action, and minimum release or no release of histamine, has vagolytic action and causes tachycardia can occur. Third group is dexacurium. It is the most potent non-depolarizing blocker, minimum histamine release, has long duration of action and mainly excreted in urine. And pipecuronium is long duration of action and may cause bradycardia and hypotension can occur. Vacuronium, one of the commonly used neuromuscular blocker, has intermediate duration of action, minimal or no tendency to release histamine or cause cardiovascular as the blood-brain barrier. So CNS side effects are less. Atracuronium is the intermediate acting and undergoes spontaneous degeneration in the degradation in the plasma, and it is called Hoffman degradation in addition to destruction of cholinesterase, and cause histamine release, and safe in patient with the renal dysfunction because it is eliminated through plasma or Hoffman degradation. Curium is the intermediate duration of action and more potent than the atacurium. Does not cause histamine release, undergoes spontaneous degradation in the plasma. It also degrades in the plasma and it is Hoffman elimination or Hoffman degradation. Rocuronium, it is intermediately acting and minimal or no tendency to release histamine. Has rapid onset of action. Now mevacuronium, it is shortest rapidly inactivated by plasma cholinesterase and does not require reversal causes of histamine release, and duration of action is prolonged in patient with pseudocholinesterase deficiency. So action of the non-depolarizing blocker are it is competitive blocker and produce flaccid paralysis. The order of the muscle affected in extrinsic first is the from above to below, like eye muscle, neck muscle, face muscle, hands and feet muscles, limbs, trunk, and finally respiratory muscle are involved. Intercostal muscle and diaphragm are lastly involved, but recovery occur in the reverse manner. Like respiratory muscle are first recover and consciousness and appreciation of the pain are not affected. DTC, mevacuronium and etacuronium causes histamine release and which manifest as hypotension and bronchospasm. These three drugs also having cardiac adverse drug reaction like hypotension and cardiovascular collapse also seen with these drugs. Pancuronium, vacuronium, dopuronium and rocuronium having less tendency toward the histamine release, but cardiac vacuronium, doxacuronium, and rocuronium having less tendency toward the cardiovascular adverse effect like hypotension and cardiovascular collapse. Among competitive neuromuscular blocker, rocuronium has rapid onset of action and can be used in the endotracheal intubation. Now, pharmacokinetic of neuromuscular blockers are they are a quaternary ammonium compound and highly ionized and poorly absorbed from the GI mucosa. They are administered intravenously and mainly confined to extracellular space, do not crosses the placenta as well as blood-brain barrier. They are metabolized in liver and some are excreted unchanged in urine. Adverse effect of the non-depolarizing drug are like hypotension and bronchospasm occur due to release of histamine, respiratory paralysis, and aspiration of the gastric content can occur. Now, drug interaction of the skeletal muscle relaxant like aminoglycoside, tetracycline, clindamycin. All these drugs inhibit the release of acetylcholine from the motor nerve ending and potentiate the effect of non-depolarizing blocker. So, a requirement of the dose reduction in patient treating with this kind of the antibiotic. Now, interaction between diuretic and non-depolarizing blockers. So, hypokalemia occur due to thiazide or loop diuretic may potentiate the effect of the non-depolarizing agent. Other is the succinylcholine plus thiopentone. These are the chemically incompatible. So, it is not used in one syringe due to precipitation when mixed in the same syringe. General anesthesia and non-depolarizing blocker, ether has curare mimic effect on the skeletal muscle. So it enhances the effect of the non-depolarizing blocker. Now factor affecting action of the neuromuscular blockers are pH changes, metabolic acidosis or respiratory acidosis increase the duration of the block. Hypothermia, it potentiates the neuromuscular block by the delaying the metabolism or elimination of thistle. Myasthenia gravis is the highly sensitive to competitive neuromuscular blocker. Aminoglycoside antibiotic, they also potentiate the effect of the both competitive as well as non-competitive blocker and inhibit presynaptic release of acetylcholine. Inhalation anesthesia like halothane and isoflurane ketamine increase the effect of the neuromuscular blocking agent. Now, uses of neuromuscular blocker are it is adjuvant to general anesthesia for producing satisfactory skeletal muscle relaxant during surgical procedure in abdominal and thorax or orthopedic surgery. Succinylcholine is preferred for the short procedure like diagnostic endoscopic, endotracheal intubation or orthopedic manipulation. And vecuronium is commonly used in the routine surgeries. Pancuronium and pipecuronium are used in surgeries for longer duration. Succinylcholine and mevacuronium is the used during the electroconvulsion therapy to prevent trauma during convulsion. For tetanus and status epilepticus, when not controlled by other drug, competitive neuromuscular blocker can be used. Competitive neuromuscular blocker like vecuronium can be used for the ventilatory support in the critical ill patient and reversal of the neuromuscular blockade. Idofonium, neostigmine, by increasing the concentration of the acetylcholine as effect of the DTC and other competitive neuromuscular blocker. Now directly acting skeletal muscle relaxant like the dantrolene. Dantrolene is the directly acting muscle relaxant. It inhibits depolarizing induced calcium release from the sarcoplasmic reticulum and produce skeletal muscle relaxant. It inhibits the ryanodine receptor are present in the sarcoplasm and which inhibit the further release of the calcium from the sarcoplasmic reticulum. So ryanodine receptor 1 are present in the skeletal muscle, so it blocked by the dantrolene. When ryanodine receptor 1 2 are present in the heart, so which is not affected by dantrolene. So intravenous dantrolene is the life-saving drug in malignant hyperthermia. It is used orally to reduce spasm in multiple sclerosis, cerebral palsy, spinal injury. Side effects like drowsiness, diarrhea, dizziness, headache and fatigue, and rarely hepatotoxicity can occur. Next is the botulinum toxin. It is obtained from the Clostridium botulinum gram-positive anaerobic bacteria. It is normalize the tone in the hyperactive or spastic muscle. When used, it is given locally. It is given intradermally for the anti-wrinkle effect in cosmetic purpose into the muscle in multiple doses of spasticity or dystonia. Botulinum toxin A is injected under ultrasound guidance into the salivary gland, siloria or trulline. Adverse effects are pain at the site of injection and muscle paralysis, and occasionally rashes can occur. Botulinum toxin prevent the release of acetylcholine into synaptic cleft by inhibiting necessary protein to release the acetylcholine. Thank you for watching the video.